Thank you, Eric. And now I'd like to invite Dr. Lynne Harlan, who's from the NCI, and is going to be talking about the AYA Hope Study.
Thank you, Ashley. Today I'm going to be talking about the AYA Hope Study, the Adolescent Young Adult Health Outcomes and Patient Experience Study. The study was funded by the National Cancer Institute with support from the Livestrong Foundation, and these are a list of some of the collaborators. The data that I'm presenting here is the work of a lot of individuals who have participated in the AYA Hope Study. The study was started partially in response to the PRG that was that people were talking about earlier. So the study objectives were to understand the feasibility of obtaining a population-based sample, getting parent, guardian, or patient consent to participate, collecting medical records, both hospital and physician office, and having patients complete a survey, either paper or web-based. We wanted to address potential factors related to gaps in research and examine factors related to access to care, treatment, follow-up, and the impact of cancer. This population was slightly different in that we wanted it to be population-based from a diverse geographic population treated in the community. So unlike hospital-based studies, these patients had no previous relationship with the investigators from the study. So the accrual was from 7 surveillance, epidemiology, and end results population-based cancer registries. Eligible patients had germ cell, ALL, Hodgkin's, non-Hodgkin's, and sarcoma. They were all diagnosed between the ages of 15 and 39. Between July 2007 and October 2008, they were 6 to 14 months post-diagnosis and were administered a second questionnaire 15 to 30 months post-diagnosis. Getting this study started was a bit of a problem. We had to get IRB approval from 9 separate IRBs, one from each of the registries, the state of California and NCI. We mailed packages to the patients, which included a bracelet, a Livestrong bracelet, because we thought that if the patients received something else in what appeared to be just a bunch of papers, they'd be more interested in opening the package. And then when they saw it was a Livestrong bracelet, hopefully it would encourage them to participate. The 15 to 17-year-olds had to have their packages mailed to their parent or guardian. So the recruitment was from the population-based registries. About 1,400 patients were potential eligibles. We ended up mailing to about 1,300 patients. We had quite a number of lost to follow up. We had extensive tracing, but despite that, 209 remained lost to follow up. We had 447 who either actively or passively refused to participate, and ended up with 525 completed survey forms. We were interested to see that the majority of the forms were the paper forms rather than the web-based survey. I had anticipated that people would be more, in this age group at least, would be more likely to fill in the web-based. The patients did receive $25 for the survey and $25 for time spent completing the healthcare provider and medical records release. We finally obtained 490 medical records. So the final sample for surveys was 524 cases. Few ALLs and sarcoma cases were included in this population. These are the registries that participated. The overall response rate was 44%, with a high of 60 and a low of 30. The survey data included information about education, work, current status, and has there been any change, race, ethnicity, living arrangements, marital status, if the patient was responsible for children under the age of 18, insurance, and through whom was the insurance provided, and had there been a change. The PEDS QL, the SF-12, we had questions about the impact of cancer on relationship, future plans, information and service needs, and finally, an open-ended question. Is there anything else you'd like to tell us about your medical care or experience with cancer? We abstracted from the medical records the insurance status, whether or not they participated in clinical trials, specific therapies given, and comorbidities, as well as healthcare facilities and physician subspecialties. They could code up to 4 physician subspecialties. So responders were more likely to be non-Hispanic, white, and female. However, there were no differences by age, cancer site, income, or education, and income and education were at the census tract level. These are the sample characteristics. There tended to be more males, primarily related to the fact that germ cell cancer was one of the cancers we sampled. 40% were raising children under the age of 18, and 28% had severe or chronic comorbid conditions. Looking at quality of life from the SF-12, this is data that Ashley has published. We found that AYA Hope respondents reported 2 to 5 points lower than the general age-matched population controls on physical and mental component scores. Most were significantly worse, but the overall effect size were small. The youngest age group was comparable to the bottom 25th percentile of the U.S. general population, but the AYAO population had higher scores than the older age groups. Looking at the impact of cancer, the patients had the option of indicating that it was not applicable to them. They had generally a positive impact on family relationships, spirituality, and plans for the future and goal setting, while they had negative impacts on financial, body image, intimate relationships, control over life. We found that the older age groups were more likely to report a negative impact on finances than did the younger age groups. This is probably likely because the parents were taking care of the finances for the youngest age group. But looking at the 20 to 29-year-olds, excluding those who reported not applicable, 64% said that having cancer had a negative impact on their plans for having children. 35% of the patients reported an unmet need for service. Financial advice, 16% said that they needed help with financial planning related to health care. 15% needed a mental health counselor with a need that wasn't met. And 14% said they had unmet needs for a support group. Having unmet needs was associated with a poor health-related quality of life on multiple domains, and needing mental health services was the strongest association with poor health-related quality of life. More than 50% of the patients reported 6 or more unmet information needs, the top one being 62% reported need for information about handling concerns about getting another cancer. Non-white participants were significantly more likely to report unmet needs than non-Hispanic whites. Looking at the information needs, talking about cancer, and meeting peer survivors, in multivariate analysis, Hispanics were more likely to report that they needed information about talking about cancer with their friends and family. And as patients reported decrease in quality of care, they had an increase in the need for information for talking about cancer. The 20 to 29-year-olds were most likely to report needing information about meeting peer survivors, and both information about talking about cancer and meeting peer survivors increased as the number of symptoms reported by the patients increased. Also, both for talking about cancer and meeting survivors, as support services were needed but not received, these two needs for information increased significantly. Overall, 7% of the patients participated in a clinical trial. We asked on the survey, are there clinical trials or experimental studies available for your type or stage of cancer? You can see 63% said they didn't know. 16.6% said yes, there were. But the top reason for not participating was they felt that the treatment they might receive wouldn't have been sufficiently tested. We looked at where the patients receiving treatment, and these are not mutually exclusive categories, but you can see that only 2% of this population was treated at a pediatric hospital. The physician subspecialties, the majority of the patients saw medical hem-oncs, while only 5% of the patients saw any pediatric specialists. And when we looked at the AYAs and included only patients who were under the age of 25, and we excluded the early stage male germ cells, only a quarter of the patients saw a pediatric specialist. So the planned analysis we have, we're looking at the initial treatment. We're having difficulty coming to a consensus about appropriate treatment for each of these types of cancers. We think we're closing in on a final decision, and hopefully that'll be out soon. We're looking at clinical trials involvement, who's in the clinical trials, and if not, why not? The AYA comorbidities that were seen at diagnosis, and we're looking at the follow-up survey for medical care, fertility preservations, and insurance, both health and life insurance. So the future directions, we need to explore possible delays